Just like,
So, hello everyone. I want to extend a very warm welcome this evening to all our esteemed faculties. On behalf of the organizing committee, including Dr. Ashish Kaushal, he's the organizing chairperson and the HOD of the Department of Medical Oncology at HCG Cancer Center, Ahmedabad, where I work as well. Dr. Viraj Lavingya, he is also a consultant. We work in the same group, medical oncology group, and Dr. Priyanka Patel. We are here to discuss today the role of CDK4/6 inhibitors in the management of hormone positive breast cancer. And since the very first approval of palbociclib in 2012, around 2012, in hormone positive metastatic breast cancer, we have had a few new drugs, and these class of drugs have been widely used in clinical practice. It is our aim today to learn from the experts how they incorporate these agents in different scenarios, different patient um, uh, scenarios, and also learn from their experience. We have today two eminent guests, international guests, Dr. Hamdi Azim and Dr. Shaima Dawood. I would attempt to introduce them, although they're very well known in their own fields. We have Dr. Azim. He's a professor of clinical oncology and the immediate past chairman of the Department of Clinical Oncology at Cairo University. He's the president of Cairo Oncology Center, one of the largest private cancer centers in the Middle East region, and he chairs the scientific committee of the NCCN Middle East chapter. He has been a principal investigator in many international clinical trials and is a part of a variety of organizations to his credit. So I would like to invite him for his talk on CDK4/6 inhibitors in metastatic breast cancer from pivotal trials to clinical practice. Dr. Hamdi, please.
Thank you so much, my dear, for your kind introduction. And good evening, everybody. I'm still in the afternoon in my country. I know it's the evening in India now. First of all, I wish to tell you that I'm very happy to join this meeting and to meet, at least in the virtual life, my Indian colleagues. As we heard, we're going to discuss practically everything related to the use of CDK4/6 inhibitors in metastatic breast cancer in postmenopausal women. So we'll go first with what we have known. That's my disclosure. What we have known from the pivotal trials. As you all know, we have three practically identical in designed pivotal trials: the Paloma 2, Mona Lisa 2, and Monarch 3. The three studies, they randomized their patients to receive any of the CDK4/6 inhibitors plus aromatase inhibitor versus aromatase inhibitor plus placebo. And as you can see, the improvement in progression-free survival was very impressive, more than 43% prolongation in progression-free survival over aromatase inhibitor monotherapy, with an absolute difference at least 10 months in favor of the CDK4/6 inhibitors. But I wish to just to remind you that the letrozole as monotherapy in the provided something like 15 months as a progression-free survival in these patients with endocrinal sensitive population. When you have a look on the response rate, once more, we could touch the boundary of more than 50% overall response rate in patients with measurable disease, with an absolute difference of 11 to 15% higher than aromatase inhibitors as monotherapy. Again, I wish you to have a look on the performance of endocrinal therapy as a single agent aromatase inhibitor. It will provide to your patient a response rate around 40% and a complete clinical benefit rate of 70% in these studies in first line. In the second line, of course, the performance of endocrinal monotherapy, the fulvestrant plus placebo was quite modest. And when you add any of the three CDK4/6 inhibitors, we could improve the progression-free survival by more than 40 to 45%. Again, the response rate was more than doubled in the Paloma 3 and Monarch 2 compared to fulvestrant monotherapy. In the Mona Lisa 3, actually the overall response rate in the second line was not provided. Anyway, if you have a look on the overall survival, you see that we have good separation of the overall survival in the three studies, with an overall survival improvement strictly seen in patients with secondary resistance, the majority of the population in the Paloma 3, while in the Monarch 2, there was an overall improvement in the overall survival, whether in primary or secondary resistance. In Mona Lisa 3, the overall survival benefit in primary or secondary resistance was not provided. But the bottom line, in the second line, we can really improve overall survival, not only progression-free and overall response rate. So the CDK4/6 inhibitors plus fulvestrant are extremely effective again in the second line treatment. When you go to differentiate between the three CDK4/6 inhibitors in terms of adverse events, we see that with palbociclib in the first line, neutropenia grade 3 and 4 was the most dominant. The incidence of other toxicities in the GI and in the liver was quite small, while the incidence actually of transaminitis and nausea and vomiting, majority are low grade, but it is higher. Again, for the abemaciclib, of course, we know that diarrhea can be seen in up to 80% all grades, to something like 10% as grade 3. Some grade 3 nausea we started to see here, and again, transaminitis is not as high as ribociclib, but it is there at grade 3 and 4. The incidence of neutropenia actually appears highest with palbociclib. However, the neutropenic fever with ribo and palbo was quite low in the range of 2%. Bema as well has venous thromboembolic manifestations that was as high as 6% in Monarch 3. While ribociclib has the problem of QT interval prolongation, is something like 5% of the overall population. The bottom line, palbociclib appears to have the most favorable toxicity profile, although the three drugs can be easily used in the clinic. Importantly, last year, we had the notion that the three drugs can induce a sort of interstitial lung disease, being highest again with abemaciclib in 3%, while it was in the range of 1% with palbociclib and ribociclib. When you have a look on the quality of life in this population in the first line data, there was no deterioration when you add palbociclib to letrozole versus placebo. The time, as you can see, time to deterioration in the functional assessment was overlapping. Again, similarly, there was no significant difference when you treat with ribociclib plus letrozole compared to placebo. But if you have a look on the Monarch 3 first line, you can see that the functional scale when you use abemaciclib in first line compared to placebo was actually in favor of placebo in many subscales, like the global health status, role functioning, and social functioning. Again, in the symptom scale scores, we have certain areas like diarrhea and like nausea and vomiting and fatigue and appetite loss in favor of placebo compared to abemaciclib. Anyway, in the second line, we have the PALOMA-3 quality of life data to tell us that the quality of life was well maintained if you treat your patients with the palbociclib, while it was significantly less if you treat by placebo in the second line. Again, time to deterioration in pain scores was significantly in favor of palbociclib compared to placebo in the second line. We did not have similar data with abemaciclib. As you can see, the time to deterioration of quality of life was not improved by abemaciclib here in red compared to the placebo arm. The most important question that we raised this time is, do we have an ideal endocrinal partner with the 3 CDK4/6 inhibitor during the first line setting? And the reason of this question, of course, stemmed from the fact that we knew that fulvestrant in endocrinal sensitive population was significantly superior to anastrozole, especially for those patients, strictly for those patients with without visceral disease. And because of that, many oncologists are really interested in the use of this drug in the first line setting. So it was very natural to think whether if you add palbociclib to any of these two drugs, we will have any improvement if you give palbociclib plus fulvestrant compared to palbociclib plus letrozole. And that's why the design of the Parsifal trial, which was presented during the last ASCO, to see whether or not we have difference in progression-free survival between these two treatment arms. This is a phase 2 trial, but you can see that the sample size was actually quite large for a phase 2 trial. It reached more than 480 patients with endocrinal sensitive population. The majority of these patients did not receive chemotherapy in the adjuvant phase. And some of them received the adjuvant tamoxifen, and the other part received adjuvant aromatase inhibitors. You can see that for patients with non-visceral or visceral metastasis, there was no difference. If anything, in patients with visceral metastasis, actually, they had some signal in favor of letrozole plus palbociclib. The overall response rate in the two arms was pretty high, being 65% with palbociclib plus letrozole versus 56% in patients treated by palbociclib and fulvestrant. So the bottom line, Parsifal study did not recommend the upfront use of fulvestrant plus a CDK4/6 inhibitor versus an AI plus a CDK4/6 inhibitor. The argument, of course, may still be raised in postmenopausal women. We have data from the MONALEESA-3 trial to tell us that the median overall survival may be improved if you start with fulvestrant plus ribociclib. This kind of improvement we did not see in the other studies, pivotal studies, that used the first line aromatase inhibitor plus a CDK4/6 inhibitor like the MONALEESA-2, PALOMA-2, and MONARCH-3. That's how you see the overall survival curves, Kaplan-Meier curves, which was provided last year in the ESMO to tell us that the overall survival with the ribociclib plus fulvestrant was better than placebo fulvestrant with a good hazard ratio, although it crossed a little bit beyond the one line. Of course, they did not provide the p-value for this, but anyway, the curves, they look well separated. Again, the study provided acceptable adverse events for the combination with maintenance of the quality of life. As such, this trial was seen by many colleagues that it can be a potentially practice changing because of the overall survival difference. However, still I have my concerns because the caveats, we have so many caveats we can discuss later in the design of the Mona Lisa 3, but the major caveats when it comes to overall survival is that CDK4/6 inhibitors, as any subsequent therapy after discontinuation, were received by 11% in patients in the ribo arm and only 25% of patients in the placebo arm. Again, the study did not report on the overall response rate and clinical benefit rate for the first-line subgroup. Still, I wish to wait to see the results of this trial, actually, the SONIA trial, which is designed and conducted by our colleagues in Netherlands to see whether it should be the first-line treatment, a CDK4/6 inhibitor plus an AI versus AI alone, with a mandatory crossover to fulvestrant in the second line plus CDK4/6 inhibitor versus fulvestrant alone. By doing this trial, we will see whether we have a better sequence or it will turn out to be the same in terms of overall survival. But at the present time, what we understood from Mona Lisa 3 was quite impressive, which is actually you can achieve 3 years overall survival with this treatment in up to 75% of the population of metastatic breast cancer. Importantly, if you have a look on the overall survival curve that was generated from the Parsifal study, you can see whether you give palbociclib with letrozole or with fulvestrant. You can see here that the overall survival again is identical. So if the question, do you have an ideal first-line treatment with a CDK4/6 inhibitor, my view is that letrozole and palbociclib combination remains a standard of care in this situation. The superiority of fulvestrant plus palbociclib was not seen, and even non-inferiority was not confirmed in terms of progression-free survival. And when you start with letrozole and the CDK4/6 inhibitor, rather than you start with a fulvestrant plus a CDK4/6 inhibitor, and if your patient has a PI3 kinase mutation, then she may benefit from alpelisib plus fulvestrant in case of disease progression, which we learned from the BELIEVE study that was presented during the last ASCO here in patients who failed first-line treatment with any CDK4/6 inhibitor and aromatase inhibitor. Then if you give alpelisib plus fulvestrant, you can achieve a progression-free survival of 7 months. And as such, this data set may provide the first evidence of a good treatment after failure of a CDK4/6 inhibitor. Importantly, you may argue that should we give aromatase inhibitor on all patients with endocrine sensitive population, especially for those with the estrogen receptor mutations, and we have a lot of data to tell us that aromatase inhibitor in this population, they do not serve a good partner for CDK4/6 inhibitors. Anyway, if you leave now the arena of pivotal studies and go to the real world and see why we do a real world data, because actually we miss so many important things in pivotal trials. First, we miss the efficacy and safety outcomes of these drugs when the real world are treated in the real world hospitals by the real world physicians and nurses, adopting the real world follow-up and monitoring visits, acknowledging the real world racial, genetic, and environmental diversity. Importantly, the first 4 items in the real world are not always as favorable as what happens in the randomized clinical trials. Let's see again what happens in the randomized clinical trials. Actually, they randomize patients into a new treatment or a new treatment protocol versus the standard of care. And they are designed to show causality, which means the link between this treatment and the outcome. and they measure efficacy and safety of an intervention in a specific patient population with certain rather rigid inclusion-exclusion criteria, and they utilize the pre-specified uniformly assessed endpoints. And in order to do that, of course, these trials are conducted in a highly monitored, controlled environment. If you move to the real world studies, they provide insights into practice pattern across diverse clinical settings, across geographies, and in patients not necessarily eligible to be included in clinical trials. They assess patient-reported outcomes if it is a prospective design, such as quality of life and satisfaction with therapy in real-world setting. They measure effectiveness and safety of an intervention under real-world conditions, but they cannot actually confirm causality. They may serve as hypothesis generating. Why is that? Because real-world data are often evaluating non-equivalent groups. They do not randomize patients, and hence we have a wide range of bias may be introduced by many factors actually. So they have doubtful causal interpretation in many instances. To overcome this inherent bias in the real world data, a new statistical technique has been introduced, which is called propensity score matching. This propensity score matching actually is not very new, but it has been now newly adopted by many research groups. The essence of this approach is try to estimate the effect of any treatment by accounting for the covariates that predict treatment outcome. This is an ideal technique for statistical analysis of the observational data for the purpose of reducing the bias in the comparison between non-equivalent groups, and for the purpose of making causal conclusions as much as possible from observational data. But in order to be able to do this, in addition to having a very good statistical analysis and experts in statistics, you need a large completed database in order to go for this kind of statistical analysis. And all of a sudden, during the last 2 years, we started to hear about the so-called Flatiron network database. As you can see, this huge database is the largest in the world at the present time. It includes more than 2 million cancer patients, having been treated with more than 2,500 oncologists in more than 250 cancer centers and other 800 cancer clinics, actually. As such, it represents a very good database if you wish to go for the so-called real-world evidence. The first study stemmed from this database. It was called the Flatiron study that compared palbociclib plus letrozole versus letrozole alone in the real-world data in US. And after post-propensity score matching, they reported data on more than 900 patients, half of them treated with letrozole alone, and the second half treated with palbociclib and letrozole. That is the patient characteristics. Without going into the details of that, you can see that the patient characteristics actually, when compared to PALOMA-2, they were older patient population. The median age was 8 years older, and they have less endocrine sensitive disease, less visceral disease, and more bone-only disease. So they were not identical actually, but the two groups were extremely matched. And we have seen that in the progression-free survival analysis, that the hazard ratio for improvement in favor of palbociclib compared to letrozole alone was very identical to what we have seen in the PALOMA-2, the hazard ratio of 0.54. And we could see improvement in overall survival in favor of the combination, with a 2 years overall survival of 80% in the patients treated with the combination versus 63% in the patients treated with letrozole monotherapy as first-line treatment. And this provided the first data set in patients treated in the routine clinical practice, not only in USA, but also in all over the world. And in this study, we have seen that after utilizing the propensity score matching, that we have a progression-free survival and overall survival in favor of the combination. And of course, this data could complement what we already have learned from the pivotal trials. Actually, the propensity score matching is now getting into practically all kinds of studies. And we have seen during the last ASCO, the group of Dr. Rugo, when they presented the data of alpelisib plus fulvestrant, the BELIEVE study, they utilized the database coming from the Criterion database combined with the Health Foundation Medicine in order to get the clinical genomics data from this database. And they compared this utilizing the propensity score matching with what already is utilized in the real life after failure of CDK4/6 inhibitor in patients with PI3 kinase mutation. And after adopting this technique, they could show us that patients treated with alpelisib and fulvestrant, they fared much better compared to the real world data coming again from the Flatiron database. The real life studies can go prospective, of course, not always retrospective. And in this kind of studies, we have seen the Polaris study, which included more 1,500 patients from different academic and community centers in US and in Canada. The group was headed by Dr. Tripathi from MD Anderson Cancer Center. And actually, they have data collection prospectively collected related to the treatment pattern and quality of life and other biomarkers. And what I wish to show to you today is the kind of data we learned from part one of this study, which included the pattern of utilizing palbociclib in the real world data. We could see that the majority of medical oncologists in the real world, they utilize the full dose of fulvestrant as a starting dose, although a minority still prefer to go for a less dose as a starting dose. What was very important for me to see here is that dose interruption actually in the real life is much less than we have seen in pivotal trials in the PALOMA-2, for instance, when compared to Polaris study. And the dose reduction was more or less the same in this study compared to the PALOMA-2. In patients with recorded adverse events, you can see that the adverse events first recorded, they look a little bit less than we have seen in the PALOMA-2 study. Neutropenia, leukopenia, anemia, and fatigue were a little bit less than what we have seen in the PALOMA-2. Mind you that in the Polaris, it was investigator reported, not as strict, of course, but it is quite comfortable to see that the pattern of side effects is more or less the same. Although it is important for me to remind everybody that anemia and fatigue, they show a little bit of cumulative increase over time. So we have to pay attention for that anyway. What again we learned from the Polaris study was something we never saw prospectively in in the pivotal trials, which is the performance of these agents, the palbociclib, in elderly patients more than 70 years of age, in terms of the G8, which is geriatric aid tools to assess frailty and functional status of these patients. And again, the patient assessment of activities of daily living tool. These two tools are very important to show to your elderly patients whenever you wish to discuss with them the merits of using palbociclib for their treatment. And you can see that at the baseline, that was the situation. We have a majority of patients with impaired G8, less than 14 or up to 14. And after treatment, they more or less remained at the same percentage after treatment. And again, for the normal activities versus impaired activities, they remain the same. So it is very, really comforting for everybody to see that if you treat elderly patients with these drugs, with palbociclib, you do not expect any real impairment of their performance. So real-world data actually adds to the body of evidence of therapeutic agents, and it expands the use of these agents in patient subgroups not typically represented in clinical trials, especially elderly and those with poor performance. In patients with ER-positive, HER2-negative metastatic breast cancer, safety and efficacy of palbociclib has been shown in pivotal trials, and this was further complemented in the real-world data. Dosing and frequency of dose adjustment in the real-world studies are somewhat different. They are not identical. In general, we have less dose interruption in the medical community compared to the pivotal trials. And important to remind you that the introduction of real-world studies is now taking place with other CDK4/6 inhibitors and PI3 kinase inhibitors. However, neither the pivotal trials nor the real-world data will tell you how to make an optimal treatment decision in the clinic. That's why we have provided our thoughts in this publication we provided last year to the breast journal. Dr. Shahina was the co-author in this article as well. We mentioned that in endocrinal sensitive population, of course, first-line CDK4/6 inhibitor and an AI are considered as the standard of care in the majority of patients. Still, we lacking the overall survival data in postmenopausal women. And of course, we lack again predicted biomarkers. But here, cost, adverse events, and patient preference are important factors in your decision. The most important caveat of this decision is we don't have an idea how these patients will respond to salvage second-line treatment, although we know now that alpelisib and fulvestrant can be suitable in patients with PI3 kinase mutation tumors. Again, in the first line, endocrine sensitive, single agent endocrine therapy is still a valid option. You can see that in all guidelines, especially in patients with low tumor burden. Remember that the clinical benefit of AI or 70%, which is pretty high. If you give first line single agent, still your patient can benefit from second line CDK4/6 inhibitor. We have seen that the outcome of these agents is pretty well. Therefore, first and second line options should be considered together in our mind at the original treatment plan of our patients, because second line will always depend on your first line choice. So without validated biomarkers, clinical factors should guide therapy decision before you choose the first line treatment. I ask you to always set your treatment goals. If you have a patient like this, endocrine sensitive disease with mildly or non-metastatic symptoms, non-visceral low tumor burden disease, in this situation, single agent treatment can be contemplated because what you need to achieve here is to prevent disease progression. Here, a stable disease can be okay for you. You want to retain the already good quality of life, and you have to consider patient preference, social and financial aspects, and single agents, as you can see, can provide very good response, and you can certainly utilize a CDK4/6 inhibitor in the second line. But if you have a patient like this coming to you with de novo breast cancer, large primary and nodal disease, and large lung metastases, and few satellites in the lungs, the patient is suffering from some shortness of breath, a high tumor burden, visceral disease, you have to think of your aim. My aim here is to have rapid relief of symptoms, so I need a regimen with high response rate. I want to prevent disease-related complications, and I want to improve the impaired quality of life. In this situation, in my opinion at least, the best treatment is to give your patient a CDK4/6 inhibitor plus endocrine therapy, and this is certainly required here. So I will take you to more details in this case. One of my patients who had early breast cancer treated several years ago by breast conservative surgery for a T1 M0 N0, ER and PR highly positive, KI low 18%. She had all risk factors in the globe actually. So she received after surgery radiation therapy and adjuvant tamoxifen for 5 years. That was ended by July 2018. And then 10 months after the end of tamoxifen, she had progressive vague abdominal pains becoming very severe during the last week with new onset of hypertension and increased creatinine, which was never there before, with abdominal sonography and non-contrast CT showed us this. This is a large mass para-aortic, lower para-aortic, apparently, with dilatation in the two renal pelvis and two ureters. So she had hydroureter, hydronephrosis. And of course, the first thing you have to consider here is to do that. You bring your urologist and ask him to introduce this kind of ureteric catheters in order to get rid of the increased renal back pressure. And after doing this, we had a PET scan that showed this disease. It is not visceral disease. It is multiple nodal disease compressing the ureters, the renal pelvis, and again, some peritoneal nodules and portohepatic lymph nodes and stuff like this. We introduced a needle in one of the lymph nodes, and again, it came out to be ER and PR 6/8, KI a little bit high, 35, with a grade 2 disease and HER2 negative. So the question, according to the ABC definition of endocrine sensitivity, is this disease primary endocrine resistance or secondary resistance or high endocrine sensitive disease? And of course, according to the strict definition, because the definition is relapse anything more than 1 year from the end of adjuvant treatment. And she relapsed 10 months from the end of adjuvant treatment. But for me, and because she received the adjuvant tamoxifen, I consider this as endocrine sensitive disease. And hence we can apply the studies like PALOMA-2, for instance, for her treatment. So if you wish to put your aim here, your aim is to reduce the highest possible tumor size reduction, to induce the highest possible tumor reduction. or to prevent early disease progression, or to secure disease stability. And of course, for these patients with symptomatic disease and with bulky nodal disease, my aim should be to have the highest possible tumor size reduction and to prevent early disease progression in order to prevent the deterioration, another deterioration of the renal function. So we started with a baseline images like this. And after 3 months from treatment by palbociclib and letrozole, we have good tumor shrinkage actually. And then after 1 year, the patient was in a very good partial remission. Still, you can see the renal, the bilateral ureteric catheters there still inserted. We failed actually to get them out. And then that is after 2 years from the start, after 3 years from the start. And actually we have to do some dose reductions because of neutropenia and because of fatigue. So my final take-home message is that letrozole and palbociclib combination remains a very good standard first-line treatment for patients with ER positive, HER2 negative metastatic breast cancer. Fulvestrant plus palbo does not seem to be a better option. And single agent therapy, I still believe it can serve as a reasonable frontline treatment for some postmenopausal women with endocrine sensitive disease, especially those with non-visceral disease and low tumor burden. Estrogen receptor mutation, which we did not discuss today, has recently evolved as an important prognostic and predictive factor for patients treated by aromatase inhibitors plus or minus CDK4/6 inhibitor. Still, the utility of ESR mutation testing in the clinic is not ready for a prime time. The main message we learned from real-world data is that the magnitude of superiority efficacy with first-line palbociclib and letrozole over letrozole monotherapy is actually achievable in the real-world practice when treating a more heterogeneous expanded population, while the toxicity were within the range seen in the pivotal trials. Importantly, and this is very important for everybody actually, the overall performance of elderly women receiving palbo and endocrine therapy was quite favorable as reported in the Polaris study. To this end, I come to my last slide and thank you for your attention.
Thank you, Professor Hazim. That was very helpful. I think it helped us make sense of a lot of data that is out there from clinical trials as well as from real-world practice. And I think we will go ahead to the next session, which is going to be modeled by Dr. Shaina Dawood. So I don't want to, I think we'll discuss all these issues in the next session. I would like to introduce Dr. Shaina Dawood. She's the head of medical oncology and the head of breast cancer program at Dubai Hospital, UAE. She's also the co-director of the Middle East Research Network. And, she has been in a part of a lot of academic meetings and a part of a lot of regional cancer guidelines. So I would like for Dr. Dawood to go ahead and start the next session, talk about targeting CDK4/6 inhibition in hormone-positive breast cancer. Dr. Dawood, should I introduce the panelists and then maybe?
Yes, please.
Yeah?
And
Okay.
I'm assuming, because I don't see Dr. Hamdi's name, I'm not letting him go. So Dr. Hamdi, do not go anywhere. You're part of this panel discussion.
No, he's definitely going to.
I'm there, dear. I'm there. Like, okay.
So if I can also invite to the discussion our experts, we have Dr. B.K. Smruti. She's a senior medical oncologist at Leelavati and Bombay Hospital in Mumbai. Welcome, Dr. Smruti. Thank you for making it. Dr. Meenu Walia, she's a senior medical oncologist at Max Super Specialty Hospital, Delhi. Dr. Poonam Patil, very senior medical oncologist at Manipal Hospital, Bangalore. Dr. Shruti Kate, consultant medical oncologist and HOD at the HCG Manavta Cancer Center in Nasik. Myself, Dr. Priyanka Patel, a medical oncologist with Shashwat Onco Clinic in Surat, and Professor Nazim was kind enough to stay back for the discussion, so thank you. We have predominantly female medical oncologists, keeping in view the theme of this month with being the Women's Breast Cancer Oncology Awareness Month. So Dr. Dawood, if you can take on the screen.
Thank you for the lovely introduction. Thank you for the fantastic panel. And I'm sure this is going to be interesting. Not as interesting as Dr. Hamdi's presentation. I think that was fantastic. He took us through the whole journey of using CDK4/6 inhibitors. And my job is really to just bring everything into a more practical sense of what we do in the clinic. So I thought I would ask some questions at the same time present some cases. This is a premenopausal woman. She's 43 years old. She presents with stage 4 de novo breast cancer with a pretty terrible PET CT scan, ER/PR positive, HER2 negative. Her liver function is actually unremarkable despite the fact that that liver actually looks pretty terrible on this PET CT scan. So my first question is this patient in visceral crisis? And maybe I know Dr. Smriti is out there. I heard her introduction. So Dr. Smriti, maybe you could take this away. I can see you on the panel, Dr. Smriti.
Yeah, she's not in a visceral crisis, though she has meds. Can you just please show me the last lines, please? Just go back. I'm sorry, I missed that.
So yeah, so this is the way her PET CT scan looks like. The liver is practically 3/4 of the way studded with disease.
Yeah.
And even though her liver function is unremarkable, it's, I think, a very scary picture. So
Yes,
that's
but
why
is
I've
she
asked the question.
symptomatic? Is she symptomatic with the visceral metastasis, and what is her performance status?
She only feels some discomfort in her abdomen because of the stretched liver capsule.
Is she breathless?
She is not breathless. She is not
Yeah,
breathless.
so then, I would still not call it a visceral crisis. I would, she's not symptomatic, although she has a very disseminated disease. And as you said, her performance status is acceptable, so I would not call it a visceral crisis.
Dr. Shruti, I see you on the panel as well. Welcome on board. What would you say for this patient? Do you think she's in visceral crisis or not? Or are you on the fence?
Thank you, Dr. Shaina. Yes, I agree with Dr. Smriti. This is not a visceral crisis. The patient is symptomatic for the disease, but she's not in a crisis. So, yeah.
Okay. So let's go to the next question. I think all of us would say that she's not in visceral crisis. Dr. Hamdi showed us that perfect example of a patient where, it works very well. So Dr. Minu, I see you on the panel. So what do you consider to be the optimal first line therapy for this patient? That's the reason why I've put the PET scan with the question, so you can see how, again, terrible that liver function is, or that liver PET CT is. Are you going to give chemotherapy, endocrine therapy plus a CDK4/6 inhibitor? Are you on the fence about what you're going to do here, Dr. Minu? You're on mute. You're on mute currently, Dr. Minu. If you could unmute yourself.
The lady seems to have significant visceral disease, although by definition, she's not in visceral crisis. So since she's not in visceral crisis, I will not opt for chemotherapy. My choice will definitely be endocrine therapy plus a CDK4/6 inhibitor.
So let me shake things up a little bit here, and maybe Dr. Hamdi, you can take this question. Say suppose her liver function was not unremarkable. Say suppose the enzymes were 2 times the upper limit of normal. So I've given you right that borderline. What would you do at that point, Dr. Hamdi?
Okay. Again, for me, it is dominant visceral disease, very dominant visceral disease. But we need to understand that this patient, in terms of progression-free survival, with anything, with any treatment, will not be the same like median we see for each and every study. If the median for Paloma-2 is 25 months, for instance, that's for the overall population. The median for this kind of patients for progression-free survival is not 25 months. It is in the range of 17 to 18 months. That is according to the subgroup analysis. So this is a difficult case. If it is twofold increase, I still give a CDK4/6 inhibitor. Of course, in this case, I will be skeptical to give ribociclib or abemaciclib because on toxicity not extremely common, but it is there for transaminitis. So if the enzymes are a little bit higher, I will think only of palbociclib in this situation.
So, Dr. Smriti, I'm coming back to you because I remember when palbociclib was first introduced in India, you had a patient, if I'm not mistaken, that you used palbociclib for with very high enzyme levels and very high bilirubin level.
Yes.
So let me ask you this question. What would be the cutoff of liver enzyme elevation and bilirubin elevation where you would not feel comfortable giving a CDK4/6 inhibitor? You would want to give chemotherapy? Because that definition of visceral crisis, I think, needs to be revised. I think it's more of a spectrum rather than a yes or no, black and white. So maybe you can take this question, Dr. Smriti.
Well, as Dr. Anzi said, that more than 2 times the normal, you'd still use it. Now, as I said, I had the experience of a lobular carcinoma who had progressed on, an AI, and then she was refusing chemotherapy, and her bilirubin was something like 20. And I started her on fulvestrant and a lower dose of palbociclib. And, in 8 weeks' time, she actually normalized her bilirubin. So, that was my first experience of palbociclib in bilirubin that high. Now, all these patients are excluded from trial. So I think, you have to take the call as and when. I mean, even to give chemotherapy for a bilirubin that high, then your options are limited. You can't use a taxane, you can't use an anthracycline, you can't use capecitabine. And then, even with gemcite and carbo, the patients land up with severe toxicity. So I think in a very high bilirubin, your options as it is are limited. And at least from my past experience, I would still go with this, maybe use the hormonal therapy single agent and add on palbo, or use a lower dose of palbo.
Okay. Let's go to the next part. So Dr. Hamdi's shown this very well, that using a CDK4/6 inhibitor in the endocrine sensitive setting is associated with an overall survival. We saw that in Mona Lisa 7. We've seen that in Mona Lisa 3. So I'm going to put this whole panel on the spot. I have compared Paloma 2, Mona Lisa 2, Mona Lisa 7, and Mona Lisa 3 here. So, Dr. Mansi, she's just been introducing people. Let's get her to say something. Dr. Mansi,
Yes.
why have we not seen an overall survival advantage with Paloma 2 and Mona Lisa 2? If you look at it, Mona Lisa 2 also had ribociclib, but Mona Lisa 7 and 3 actually had an overall survival advantage, and Paloma 2 was one of the first trials. Why have we not seen an overall survival advantage in Paloma 2 and Mona Lisa 2?
I think it has a lot to do with the patient population. If you look at the Paloma 2 trial, I think they did have a few patients, I think, in terms of the endocrine sensitivity, the inclusion criteria, I think, were different. I think that was probably one of the major reasons in terms of the overall survival advantage.
Okay. Dr. Poonam Patil?
Yeah, there was no specific reason that could have been made out actually, in spite of dissecting all these studies, that why did Mona Lisa show. But yes, their patient population was a little different. There was a difference in the definition of endocrine resistance also, a little bit in the Paloma, in the Mona Lisa, and in the Monarch trials as well.
Okay. So going back to Dr. Hamdi, because
Yeah.
I like to ask him the toughest questions ever. And I want to know, Dr. Hamdi, the overall survival advantage that we saw in Mona Lisa 7 and Mona Lisa 3, will this influence you as to which CDK4/6 inhibitor you will use in the first line setting? Are you going to be more likely to use ribo rather than palbo and abema, or do you think that the efficacy in the first line setting, the overall survival advantage is probably the same, and it's just the way that these trials were designed that has resulted in these differences? Take it away, Dr. Hamdi.
Okay, thank you, Shahina. Very, very, very intelligent question, as always. Mona Lisa 7, my dear, was in premenopausal women. And if you go and dig into premenopausal women, you will see that premenopausal women, there are two categories of patients. Patients above 40 years of age, which behave in a similar way to postmenopausal women, and patients up to 40 years of age, which they have inherently poorer prognosis. And we have seen this in 1,001 trial in the early breast cancer studies. So we're sure that postmenopausal women are quite similar to premenopausal women above the age of 40. But below the age of 40, we have poorer natural history. The natural history is much more aggressive, and the genomic profile is totally different below the age of 40. So the situation in Mona Lisa 7 is that we have early events of survival happening earlier, because this was dominated by being a more aggressive disease, particularly in women below the age of 40. So this is not, for me, unexpected that we have overall survival maturation in Mona Lisa 7. Events happened earlier compared to postmenopausal women, the Paloma. What was peculiar for me actually is the Mona Lisa 3, because Mona Lisa 3 actually, they utilized fulvestrant, and they reported in postmenopausal women, endocrinal sensitive. So in this kind of thing, they have included endocrinal sensitive subset and endocrinal resistant subset. So they reported overall difference at a median period of 40 months, which is quite short for postmenopausal women, actually. But the major caveat is that in the Mona Lisa 3, patients receive any CDK4/6 inhibitor in the placebo arm was quite low compared to what is expected. Only 25% in the placebo arm, they were treated by a CDK4/6 inhibitor, which is not really expected at the time of this trial was conducted, because at that time CDK4/6 were practically available for everybody. That's why I need actually to see the overall subgroup for patients who were receiving a CDK4/6 inhibitor at the time of disease progression, to see this kind of subgroup analysis, to see whether the survival was altered or it was the same like who received ribo plus fulvestrant as first line.
So, Dr. Priyanka Patel, if I could ask you the question, in a premenopausal woman, say suppose she's 36 years old, she's got metastatic disease, hormone receptor positive, HER2 negative, and you've rendered her postmenopausal, which CDK4/6 inhibitor would you use in the first line setting? Do you have a preference, or do you think all three are equal?
Good evening, Dr. Shaina. Yeah, so as such, I don't have a preference for using any CDK4/6 inhibitor one over the other. Ribociclib versus palbociclib, efficacy-wise, of course, all are same. Abemaciclib is little bit difficult to tolerate because of side effects like diarrhea but in palbociclib versus ribociclib, yes, we can use either one. I don't have any preference.
Dr. Smriti, do you have a preference in the first
From
line
my
setting?
agency,
Well, if you have to look at the data, then it's the Mona Lisa 7, which is totally a premenopausal patient population. Although you have subset of populations with palbociclib and also with edema, but they were part of a larger population. It was not a dedicated premenopausal. So if you look at that data, then I would go for ribociclib. But as mentioned by Dr. Priyanka, there really is no difference between the three. So you could use either.
Okay, all right. So I feel like people are split in terms of their thoughts over here. Personally, I think the efficacy amongst the three CDK4/6 inhibitors are exactly the same. It's just that these trials have been designed very differently, but you could make arguments for both. Now, Dr. Hamdi actually in his presentation did talk about the Falcon trial, fulvestrant versus anastrozole in the first line setting, and we saw that there was an improvement in progression-free survival when you gave anastrozole. Specifically in patients without visceral metastases, there was a nice improvement from 13.8 to 22.3 months. And in patients with visceral mets, it was exactly the same. He also showed the results of the Parsifal trial, which was the phase 2 clinical trial that randomized patients first line endocrine sensitive to receive either fulvestrant or palbo or letrozole plus palbo. And you can see exactly the same Kaplan-Meier curves are practically overlapping each other. So really giving us the opportunity to use any of the endocrine therapeutic agents upfront in combination with a CDK4/6 inhibitor. So in this particular patient with that terrible PET-CT scan, what endocrine therapy agent would you choose in combination with the CDK4/6 inhibitor? Maybe Dr. Shruti, maybe we can go with you, Dr. Shruti.
Yeah. Did you say Smriti or Shruti?
Shruti.
Okay. Sorry.
It's a privilege that our names sound so similar, ma'am. So I would, ma'am, choose AI over fulvestrant if I'm using it in the first line setting. So I know the data is quite tempting, but I would want to utilize AI first in the first line setting. And this is a disease where you are talking about more of resistance, but I would say that it is more about endocrine sensitivity. And in the first line setting where the patients are endocrine sensitive, sort of a situation where there I would preferably would want to use an AI. I would want to render the patient post-menopausal using an LNRH, and then I would want to use an AI in the first line setting, along with the CDK.
Okay. So then at at the European Society of Medical Oncology in literally about 3 weeks back, we saw a very interesting trial, which was the phase 2 Flipper trial. This trial randomized patients in the first line setting to receive either fulvestrant or fulvestrant plus palbociclib. And you can see in terms of progression-free survival, there was an improvement. If you look at patients with visceral mets, there was an improvement. And if you look at patients without visceral mets, there was an improvement. So in a patient with bone-only metastases, what would be your choice of therapy? Would it be fulvestrant alone, AI alone, tamoxifen alone, combination endocrine therapy with a CDK4/6 inhibitor, or are you going to stay on the fence for that? Dr. Meenu Walia?
So in a bone-only mets, in spite of whatever the data that we are talking about, my preference will be a CDK4 plus a AI upfront. I would like to reserve fulvestrant for second line, knowing that now that we have PIK3 inhibitors also. And for a limited bone mets, I mean, maybe just 1 or 2 lesions, possibly in that subgroup, as we discussed earlier, probably AI alone may be something which I might do.
Okay, Dr. Priyanka?
So, doctor, so in patient with bone-only mets, considering the results of Falcon trial and you have just shown the results with Flipper trial, yes, we can consider fulvestrant alone. So technically, to be very honest, we can do both. We can do fulvestrant or we can do endocrine therapy with CDK4/6 inhibitor if we wanted to give best therapy upfront to a patient. So we don't really have that much data about, and we don't have any comparative study that shows in bone only mets CDK4/6 inhibitor first line versus second line inhibitor. So we have to wait for the results with Parsifal trial.
Okay. Dr. Poonam? You're muted, Dr. Poonam.
Yeah, I would agree with Dr. Meenu, and I would say that I would use AI with CDK4/6 inhibitor in this scenario.
Brilliant. So let's make things more interesting. So I tend to do a lot of molecular profiling of my patients here in the UAE, and it usually gives some very interesting results. This is a 40-year-old woman. She presented with a breast mass. It was biopsied. It was ER/PR positive, HER2 negative. PET-CT showed a solitary metastatic deposit, and we biopsied that. We sent it off for profiling, and you can see on the molecular profiling, she's got a PIK3CA mutation. And 40% of patients up front will have a PIK3CA mutation. Interestingly, she has high genomic loss of heterozygosity. And more interestingly, she has a pathogenic HER2 mutation. Now, I thought this was all very interesting. Now, if you go back to the Solar 1 trial, we saw the results of we saw the updated analysis of Solar 1 at ESMO this year. Progression-free survival, we already knew in patients with PIK3CA mutated positive disease, there is an improvement with alpelisib and fulvestrant. In terms of overall survival, there was a 7.9-month improvement, although not statistically significant. And in patients with lung and liver metastases, there was a 14.4-month improvement in overall survival, but again, not statistically significant. We know as well from the plasma match study that in patients with HER2 mutation positive disease, the combination of neratinib plus fulvestrant has good activity, which was also shown in the Summit Basket trial. So what do you consider to be the optimal first-line therapy for this patient? Dr. Mansi, maybe you can take a crack at this. Will you give her endocrine therapy alone, endocrine therapy plus a CDK4/6 inhibitor, endocrine therapy plus alpelisib? She has a PIK3CA mutation. Endocrine therapy plus neratinib. She has a HER2 mutation. Chemotherapy, or you don't know?
So I think this is very interesting, and we don't get to do a lot of these molecular studies upfront because of cost issues, but definitely interesting. So I think in this patient, even though she has a PIK3 mutation, I'd probably choose endocrine therapy plus a CDK4/6 inhibitor for the first line setting, and probably save alpelisib as second line setting based on the by leaf trial data, which shows that it would still work second line. We have no data to suggest that CDK4/6 inhibitors don't work in these patients in the first line, and so because we have probably a better safety profile than alpelisib, probably choose option 2 first. I actually have not used neratinib, and so I don't think I have an opinion on using neratinib, but first line probably would go with option 2.
Dr. Smriti, what would you do in this patient?
As far as the PIK3CA mutation is concerned, I would still use a CDK4/6 inhibitor with endocrine therapy as first line, and then the fulvestrant with alpelisib as second line therapy. But as far as the mutation in the HER2 is concerned, we don't have the data of how a CDK4/6 or an alpelisib would behave in the presence of HER2 mutation, because the plasma match was done on patients who had progressed on, I think, 2 lines of endocrine therapy, and then the plasma match was done. So I think I would still stick to the same sequence, and then use if I had access to neratinib, then use that as a third line. But really, there is no data to really guide us.
Okay, so I hear what everyone is saying. So everyone would use a CDK4/6 then probably alpelisib-based therapy. And then if you really want to be cool about it, you do neratinib plus fulvestrant. So let's go to the next patient. This is a 35-year-old lady. She presents with stage 3 breast cancer. She's given chemo, surgery, radiation. She's then put on adjuvant tamoxifen, and 2 years later, she presents with extensive bone metastases and 2 liver mets. We do a liver biopsy. We send that off for molecular profiling, and molecular profiling shows that she's got a PIK3CA mutation. She also has genomic loss of heterozygosity that's high. Dr. Hamdi, how would you sequence treatment in this particular patient?
That's a case of primary resistance, as
Yes.
far as you mentioned, right?
Yes, primary resistance to tamoxifen.
Primary resistance to tamoxifen. Yep. Again, we have the only two studies that presented data on primary versus secondary resistance actually were the Paloma 3 and the Monarch 2, and they did not specify the primary resistance prior or prior aromatase inhibitors because it makes a difference. Prior aromatase inhibitors, the situation is more difficult. The patient, she progressed after 2 years of adjuvant tamoxifen. But anyway, the data of Paloma 3, they are more in favor of the use of palbociclib in the secondary resistance, while the data with abemaciclib in the Monarch 2, they will tell us that probably the main advantage of abemaciclib is with primary resistance. Ribociclib, we don't have data because of the design of the Monarch 3 actually. So I would use here abemaciclib plus fulvestrant probably.
Okay. All right. Let's go to the next case. This is a 60-year-old lady who has recurrent breast cancer. She has liver metastases. She had adjuvant tamoxifen as well. She has no germline mutation. And then I sent off her tissue for profiling. Interestingly, she has an ESR1 mutation at baseline. She has a BRCA2 somatic mutation. So let's make things more interesting. Dr. Manasi, what would you do in this patient? How would you sequence therapy here? She's got an ESR1 mutation. She's got a somatic BRCA2 mutation. And she's now presented to you with hormone receptor positive, HER2 negative metastatic disease.
So I think we have some data to suggest that patients who present with upfront ESR mutations, if you challenge them with hormone therapy, say even letrozole, again, some of them actually lose their ESR mutation downstream. Having said that, for a patient who's received adjuvant tamoxifen, and I would probably use a fulvestrant-based therapy. So fulvestrant plus a CDK4/6 inhibitor, any which one of them would do, and then sequence it with a PARP inhibitor. I would probably use a PARP inhibitor before using chemotherapy, just based on the fact that we have the Olympiad trial data suggesting that PARP inhibitors work better if you use them before chemotherapy. So I think, give her a trial of fulvestrant plus CDK4/6 and PARP inhibitors second line, and then say chemotherapy after that.
Dr. Smriti, what would you do?
Well, because she has the ESR1 mutation, I would agree with the previous panelists that I would use fulvestrant with a CDK4/6 inhibitor. And we know that they work equally well whether the patient is BRCA mutated or not. So I would go that way and reserve the PARP inhibitor for later line.
Okay, Dr. Hamdi, what would you do?
Yes, exactly like my colleagues mentioned. first line fulvestrant plus palbociclib, you can see that lack of benefit in red of aromatase inhibitor is put as level 3A, but because it's supported by a lot of, so I think the level of evidence, the clinical level of evidence is not very high, but the clinical and molecular level of evidence is pretty high. So I will not use the aromatase inhibitor. I will use fulvestrant plus palbociclib or any CDK4/6 inhibitor.
Okay, and would you be comfortable using a PARP inhibitor like olaparib or talazoparib in a patient?
Yeah, you have the target. You have the target in front of you. The target is present, so I will use them as a second line, which is quite rational.
Excellent.
Shaina, I just wanted to intervene. I mean, as far as olaparib is concerned, it's I think the approval is for germline BRCA.
Yes.
You said that this is a somatic mutation.
This is a somatic mutation, but as you know, at ASCO this year, we saw the results of the TBCRC trial, which looked at somatic BRCA. They not only looked at somatic BRCA, they looked at germline of other mutations like PALB2 as well. And they found that the response rates were almost 50%. So for me, I'd be quite comfortable if a patient has a somatic mutation, although it's very rare to get a somatic without a germline mutation. But this patient exactly had that, no germline mutation. She has a somatic BRCA mutation. And personally, if once she progresses on her CDK4/6 plus endocrine therapy and she's exhausted her lines of endocrine therapy, and if she's not in visceral crisis, I personally would be very comfortable using either talazoparib or olaparib. What do you think, Dr. Smriti? Okay. All right. So let's get to the really interesting stuff that we heard this year at ESMO, and that is the adjuvant use of CDK4/6 inhibitors. So at ESMO this year, we saw the results of the monarch-E trial and the PALLAS trial. As you know, the monarch-E trial and the PALLAS trial were both phase 3 clinical trials that randomized patients in the adjuvant setting to get a CDK4/6 inhibitor. monarch-E used abemaciclib, and they specifically did not enroll patients with node-negative disease. The majority of patients had node-positive disease of more than or equal to 4 lymph nodes, and about 40% of them had grade 3 disease, so a really, really high-risk population. While PALLAS used palbociclib, 13% had node-negative disease, and if those who had node-positive disease, the majority were 1 to 3 positive lymph nodes. In terms of the invasive disease-free survival, it was significant in patients who were enrolled in the monarch-E trial, the hazard ratio of 0.75, suggesting a 35% reduction in the risk of recurrence of disease, while it was not significant in a hazard ratio of 0.93 in the PALLAS trial. Now, just going into this, some of the nitty-gritty of this trial, if you look at the high-risk population of monarch-E, I told you these high risk were defined as more than or equal to 4 lymph nodes or 1 to 3 lymph nodes, and at least one of these characteristics, which was tumor size more than 5, histological grade 3 or Ki-67 of more than 20%. While PALLAS, they also defined a high risk cohort with a very, very similar definition. So when you look at the invasive disease-free survival in those patients with more than or equal to 4 lymph nodes, monarch-E was still positive, while although there was a trend to positivity in the PALLAS, it wasn't statistically significant. So my question here is, why the difference? Dr. Mansi, maybe you can take away this question. Why did we see this difference in monarch-E versus PALLAS?
Dr. If I am not wrong, I think in the PALLAS trial, there were probably more patients with stage 2 disease compared with the monarch-E trial. I think I don't remember the exact numbers, but that was probably one of the difference in the patient population. And otherwise, I mean, I really don't know why one was negative and one was a positive trial. I think just in terms of stage 3C disease, there were probably more in the monarch-E trial. So maybe a little bit more of a high risk patient population. But other than that, I'm not sure.
Dr. Hamdi, what do you think?
I think because you have shown us uh, intelligently that invasive disease-free survival for patients with 4 or more nodes was the hazard ratio, if anything, was a little bit better in Monarch 2 compared to the overall population, while it was the very same in the palace. So it doesn't seem that the high risk population is really, at least from this subgroup analysis, is really getting any preferential benefit from the added palbociclib. So many things. I believe that the two drugs are not the same. I believe that Monarch 2, abemaciclib is able to prevent more early recurrence because it works more on primary resistance. Maybe a design of palbociclib may be better if you give all patients treatment, endocrine treatment for 2 years, and then those who do not progress probably should be randomized to add palbociclib or versus placebo. Am I clear for you, Shaina?
Yeah, I think I get what you're saying. When I look
Yeah.
at this data, I feel like the patients who are in Monarch E, in the ones who are more than or equal to 4 lymph nodes, if you look at that hazard ratio, that confidence interval is very, very wide. And that has
Yeah.
just barely reached statistical significance at 0.99. Like, they just about made it.
Yeah.
So, Dr. Minuwalia, maybe you can
But if you allow me,
Yes, Dr. Hamdi, please.
This needs further follow-up because
Absolutely,
the
yes.
follow-up period is short. So we need to see more how this will move across the wall.
Yeah, absolutely. Dr. Minuwalia, what do you think?
So I also basically think the same. The difference what we are finding is the difference in the patient population. We are considering the difference seems to be more significant in the high risk population, and basically it comes back to that these two molecules are not the same. So as we already know, abema, although being having more side effects, but the more it is found to be more effective in the more the disease load you have. So possibly the benefit of palbo was being offset in the subgroup because there were a lot of low risk disease also, significant proportion. So adding palbo in a population which is stage 0 and a low risk does not add so much value. What abema does in a high risk population. Maybe the difference between the two molecules might explain this.
You could be right. I think there are a lot of explanations. My personal feeling is, and I could be proven completely wrong, I don't think that there is much of a difference between the two drugs. In fact, I think all 3 CDK4/6 inhibitors are efficacy-wise equal. My personal feeling is Monarch E was a very well thought out design in terms of clinical trial where they only included those very, very high risk population. And even though Palace had a subgroup that had that very high risk, it was still a subgroup of a major group. I think when you're designing clinical trials and you're only focusing on one group, you're more likely to find that benefit rather than if you have all in a mixed hodgepodge and then you say, okay, I'm going to look at that smaller subgroup. So I think statistically, also there may be a nuance there, but I'm not a statistician. This is just my feeling. So as you know, Penelope B was also a negative study. We've not seen the data. It's going to be presented at San Antonio, but we've seen a press release for Penelope B. This trial took neoadjuvant chemotherapy. Everyone had neoadjuvant chemotherapy. They had surgery, and then if they had residual disease, they were randomized to receive palbociclib or placebo. Now, obviously, I acknowledge that residual disease in hormone receptor positive patients is very different from residual disease in triple negative patients or in HER2 positive patients. So this might again not be the smartest design of a clinical trial, but the fact that it is negative, could it be that Monarch E was just a fluke and not and that we need to wait for longer term follow-up? I think it's something that we need to think about. What do you think, Dr. Hamdi?
Can you give us, please, Shahina, the design of Monopoly study, please? This is
Yes. So
of the worst designs you can ever
I
expect.
totally agree. I think Pfizer made a big mistake over here because
Yeah,
residual disease in hormone receptor positive is not the same in terms of prediction of outcome
absolutely,
uh,
absolutely.
compared to triple neg and HER2 positive. I think they were thinking it might be similar to Catherine or to create X, but this I think was not the way to go.
Absolutely, because it's a totally different disease. The residual disease does not play that important role, especially in luminal A population. And look at the palbociclib duration. It's only 1 year for a cytostatic therapy, which is again a caveat. It's unbelievable caveat to give
Yes.
therapy for 1 year. This is not done. Study was I gave my remarks to Pfizer in one of the advisory boards, international advisory boards, that the design is built not to succeed actually for
Absolutely.
for for the patient population and for the duration of treatment.
Dr. Smriti, what do you think?
Well, as I mentioned that, it's the design of the trial and that's been mentioned by all the others. And I think that's the only explanation, it's the same explanation.
Absolutely. If I could go back one slide, I know we have just a couple of minutes left. If I could go back one slide, Dr. Hamdi, I'm going to ask you, and then I'm going to ask Dr. Shruti after this to give me her thoughts. The fact that we now have the results of Monarch E, putting aside Palace, putting aside Penelope B, the fact that we have the results of Monarch E, if you have a patient with hormone receptor positive disease who after surgery has 10 lymph nodes that are positive and you give them chemotherapy and you give them radiation therapy, will you consider giving them abemaciclib in the adjuvant setting? Because 10 lymph nodes is a pretty big number, and these patients
Yeah.
are a walking time bomb in terms of the disease coming back. So would you feel comfortable tomorrow or on Monday in your clinic to actually start adjuvant abemaciclib? Dr. Hamdi and then Dr. Shruti. So Dr. Shruti,
Yes.
you have time to think.
This is a frank example of what when you should really discuss thoroughly with your patient the pros and cons of off-label use of a certain drug, because the drug is not as yet approved for this indication. But for me, if I have a young lady, certainly I will discuss with her this results, and we the adverse events and how we can work on that. And then if she approves, I may go and give her the treatment, of course.
Okay. So let me go to my next question. I think this is my last slide. Is adjuvant abema ready for all high-risk patients, Dr. Shruti?
Ma'am, I agree totally with what Dr. Hamid has said, that with results like this, you have to discuss it with your patients. Not all patients will be similar. There will be patients who are, younger in age, are very apprehensive. If there is a data like this, with all the pros and cons of the drug, we have to offer to the patient. But yes, I agree that we need a longer follow-up. Maybe this may not turn out that well, as impressive as it looks. But yes, there are some patients where, like you said, 10 nodes in a young patient who would want to go that extra mile of using something more after her treatment is complete. I data like this, you cannot like not offer that. So so you have to like intelligently offer it to the patient, and then if I was a patient, I would want to go that extra mile to do whatever I can to prevent a recurrence. So yeah.
Dr. Meenu Alia?
Yeah, sorry, I missed it. I was
So
engaged.
the question is, do you think adjuvant abema is ready for all high-risk patients in the clinic?
No, I don't really think at present. we are ready for that. We need more data and more evidence before we can really say that probably Abema can be used.
Okay, Dr. Mansi?
So I think if I have that 10 lymph node positive patient, I would definitely feel the need to discuss the data and probably offer it to the patient. But if it is, you know, not like multiple nodes and not like really high risk, probably would not offer it strongly.
Okay, Dr. Poonam?
I would definitely want to offer it because, yes, if there are more than 4 nodes, and we know that nodal positivity is the strongest prognostic factor. So, possibly that is the group who might be benefited with the Bima series.
Okay, Dr. Smruti, what do you think? Is she
I
still
think
here?
ma'am had some commitment, ma'am. She must have.
Okay. All right. Dr. Priyanka? You're
Yes,
the
I would
last
like
one
to.
that's going to answer this. This is my last slide. So you have the floor, my dear.
Thank you. Yes, I would like to, definitely, I would like to discuss with my patient with all the pros and cons. And if my patient is agree, then I guess I would like to definitely, with 10 node positive and in younger patients,
Okay.
I would like to definitely give a chance to her.
Okay, so one last question, because that was my last slide, and I'll ask Dr. Hamdi, because he knows I like to ask him the toughest questions. If you didn't have a abemaciclib in your clinic and you have the results of the Monarch E trial and you have that 10 lymph node positive patient, are you comfortable using palbo or ribo in the adjuvant as a substitute?
No, I'm not.
No. All right, perfect. So that was my last question. I think, Dr. Mansi, I'm right on time, right?
Yes.
Okay.
Just when you think you know it all, you come up with all these difficult questions. No, I think this was a great discussion. I think we have a question from one of our participants, if I can actually just read it. What is the absolute benefit in percentage points in disease-free survival, invasive disease-free survival with abemaciclib versus placebo? I think the answer is probably about 3.5%. I think 88 versus 92, right? So yeah, I think that is the absolute benefit difference, which is up for debate whether it is considered clinically meaningful or not. I don't know if Professor Azim or Dr. Dawood would want to answer that question.
I have to admit that I do not remember the exact numbers off the top of my head right now. I know that in terms of a relative benefit, it was 35% reduction in the risk of relapse of disease.
Yes, I think it is clinically meaningful, but of course, the only drawback of this trial is momentary. We need a longer follow-up to see how the separation of the progression, because with all the cytostatic treatment like Abema, we have the fear that when you stop the treatment, the Kaplan-Meier curves may start to converge. That's my only concern. So we need a longer follow-up. But if the question is at 3 years, do we have a benefit? The answer is yes. At the median follow-up of 3 years, we have.
Dr. If I can actually ask you a question. In terms of the molecular profiling, is it actually covered or is it paid by the patient?
It's I usually make the excuse with the insurance companies, and I get them to cover it 99.9% of the time. Very rarely does a patient actually have to pay for it. I feel like it gives a lot of information, as you can see. You can get information in ESR1, HER2, PIK3CA mutation. I feel like when we're doing these hotspot mutations, just looking at those individual mutation, it doesn't give you the whole story behind what's happening in terms of the biological makeup of the tumor. So this gives me more information. I know Dr. Hamdi does it as well. I know that for a fact.
Yeah, but unfortunately, I'm not in a position. You're right. Whenever we have the molecular profile, at least we can walk on solid ground. I mean, relatively solid. But in my country, the insurance does not cover in the majority of instances. I don't have the same talent how to convince them like Shahina does, but otherwise the patient has to pay out of pocket. So it's pretty expensive. So that's why we don't have a lot of experience with this profiling. But it will soon, the technology will be much cheaper over the coming 2 to 3 years. So I think we'll be able to provide this service to a larger number of patients.
Dr. Viraj Laving actually had a question. Viraj, do you actually want to ask it? Like, so he's written in the chat box, 10-year letrozole had about 3% absolute advantage over 5 years and statistically significant, but we still don't use that in practice. Then why the costly and fancy ABEMA?
So I think, that data that looked at 10 years of letrozole versus 5 years of letrozole has to be put into context. We don't use 10 years of letrozole because most of the time we'll use 5 years of tamoxifen and then we'll go on to 5 years of letrozole or any form of an aromatase inhibitor. Plus the duration of 10 years of an AI has been a constant question of a debate. I know that there's a lot of data now looking at 7 years being the ideal. And then you also have the added complexity that in your premenopausal cohort, we've started using aromatase inhibitor based on the soft and the text upfront together with GnRH analogs, while the data that you're quoting was specifically only for postmenopausal women, where we know they do much better than premenopausal. So I think that when you have a very, very high risk patient, which a lot of these trials did not have, remember they're coming from North America, and when you're randomizing patients in these trials after 5 years of letrozole, and then you randomize them to an additional 5 years, the patients that have recurred have already dropped out. So you're getting a very good cohort that's being randomized to 5 years of letrozole versus no 5 years of letrozole. But you're forgetting in that first couple of years, those patients who are recurring are the ones that are actually going to benefit from a CDK4/6 inhibitor. What do you think, Dr. Hamdi?
Absolutely, brilliant answer. That's correct in my opinion.
Okay, great. Thank you. I think we're up for time, and I would like to thank Professor Azim, Dr. Shaina Dawood, all our faculty members. I think it was a great meeting. I learned a lot for sure, and a lot of interesting questions. Still a lot of difficulty when we treat these patients in clinical practice, because putting data into clinical practice is definitely an art. I think all of us would like to master at some point. So thank you, everyone.
Thank you, dear. My pleasure. Take care.
Thank you. And we're on time. This is amazing. We're on time. Thank you.
Yeah. Bye-bye. Bye, everybody.
Bye, everyone. Bye. Take care. Bye.
Bye.